Marla, that was a fabulous interview of Elizabeth and a return visit. So what's the importance of return visits for patients with inflammatory bowel disease? Why do they need to see the doctor even if they're feeling okay?
I think one, it's to iterate a few things. One, we want to reiterate some of the information that was relayed at the new visit, because it's so overwhelming to get a list of all these things. You can't even keep track of all this new change in IBD management. So I think it's to almost reiterate some of the key points that they learned at their new diagnostic visit, to explain the importance of the therapy we've chosen. In Elizabeth's case, we had already decided that we were going to have a steroid sparing, or what we call exit strategy. She was having a lot of side effects from her steroids. She wanted to talk a little bit more about the therapy we had chosen. We chose Humira. That was her choice. We had discussed multiple options the visit prior to this visit. And we wanted to check in. I wanted her to understand the importance of why she was on this therapy.
Mm-hmm. So why can't the patient just wait until they're not feeling well and then call and come in to see the doctor? I mean, what else can you get out of a visit like this?
So historically, if you think back about how we used to manage inflammatory bowel disease, we called this reactive. You would say, here's your therapy, call me when you're not doing well. But we've recognized that that kind of approach to IBD didn't move the needle. We really continued to have patients who were perhaps non-adherent to therapies because they didn't really understand the importance of chronic management.
That's true.
They didn't understand the idea of tight control, which is this novel concept.
Well, and out of fairness, it wasn't just the patients, right? We didn't have enough treatments. We didn't even know how to get to those goals.
So, I wanted to emphasize to her, and you saw the way we talked about the GI symptoms, but I didn't spend a lot of time. I just want to know whether or not she was experiencing common side effects, for example, any skin or hair or nail changes. We focused on abdominal pain, bowel habits, because that really, in the end, when we talk about patient-reported outcome, what we want to elicit from our patients, the key things that are tied to her disease.
So, sure, she's feeling okay, but then you went one step further, right? You asked about these markers in the blood and in the stool. So what role do those play now in routine follow-up?
So similarly, what we talked about, okay, come back when you're not feeling well and I'll try and rescue what happened in between the last time I saw you. We kind of have a new attitude about inflammatory bowel disease management. We've introduced this term of objective measures of inflammation. Not that we don't care how a patient's feeling. I don't want to de-emphasize the importance of a patient saying, I feel fantastic.
Sure.
What we've learned probably over the last decade, is that even when patients say they feel well, because it's relative. I mean, before they were diagnosed and before they went on this therapy, they didn't feel very good. So automatically they feel better. The concept is, what's this new normal? And by us saying to a patient, it's not just about how many stools you're having or how much abdominal pain. We also want to make sure that objective markers of inflammation, such as SED rate or C-reactive protein, the CRP, and now we have stool calprotectin, those correlate, we know, closer to what's going on the inside, which is where the sores or the ulcers are, than even how you're feeling.
So it allows for some adjustments in therapy even after the patient's starting to feel well. Also allows you to ask them, are you taking your medicine? And are you having any trouble filling the prescription? And what else is coming up in terms of how you're going to be able to use this longer term?
I think one thing that's also important that I took away from my visit with Elizabeth is that we focused on the most important things I need to know about when she's on Humira, for example. So I asked her about injection site reactions, because that is one of the more common side effects, so you say. We weren't as focused on a lot of the rare events that may happen with these therapies.
Right.
You
also talked to her about family planning. So tell us a little bit about how that plays a role in return visits, or how patients should be thinking about that and bringing that up to their physicians.
One of the things is that we have discussed, her and I, multiple times, especially when she was flaring. She had a lot of disease activity, and she was on steroids. And she asked me, am I ever going to be able to get pregnant? I read that patients with IBD have difficulty conceiving or getting pregnant. So I kind of demystified that whole story and emphasized to her that the most important thing she can do is get on a therapy that is going to get her off steroids and into remission. Because a successful disease state in remission translates to conception, or the ability to get pregnant successfully, and to have a very successful pregnancy and a healthy baby, which is, of course, the most important thing.
Right. What else should a patient be asking about? I think that it's really important that they come to these visits with an agenda or at least a list of questions so that they can make the most of their time with the physician. Unfortunately, sometimes the visit goes, are you feeling okay? Yes. Are you taking your medicines? Yes. Thank you. I'll see you in 6 months. So what else should the patient have on their radar so that they can make the most of those visits?
And also for the physician to pick up on cues. For example, Elizabeth, she lost her job. She's looking for a job. She noted, thankfully, her husband has a job, so there's some financial security. But she was a professional and still remains when she was looking for a new job. Yeah. So that itself is stressful. Yet, what I didn't do is probably pick up a little bit more on it, and I should have really emphasized and asked her how that was impacting potentially her symptoms. Thankfully, she's a pretty resilient person, and she wasn't going to let the fact that she was finally feeling well, she wasn't going to let her lack of job impact it. But if I didn't address it, I would be remiss. I mean, the impact of the disease on mood, anxiety, is often sleep, the inability to get up in the morning, or maybe being in the restroom in the morning, being late for work, not being able to be a functioning person. And I think part of the follow-up visit allows us to be able to get through all of the classic, how are you feeling GI-wise, and be able to emphasize the things that are often missed.
That's right. What about vaccinations? You had a discussion about that. How should that play a role in the return visit, the maintenance visit, and what should patients be thinking about that?
So it's interesting. Health maintenance, which is often all about prevention, right? We talk about, if you noted, I talked to her about her pap smears. We know that in patients with inflammatory bowel disease, and specifically women who are on immunomodulators such as Humira may have abnormal pap smears. So it's critical for me to a priori tell her she needs to have regular visits, but also talk about the HPV vaccine, for example. And in the end, she did have the HPV vaccine in our previous discussions.
And you talked about skin, and you talked about influenza. So there's lots of things that can be covered during these visits, which frankly, when a patient's sick, we don't often or ever have time to really get into all those things. There's a lot that a patient can make out of those return visits. So what are your take-home messages? How can a patient be best prepared for the next return visit they have with their physician, and how often should they be scheduling them?
There's not enough time for me to see a patient ever. I want them to come in every 3 to 4 months. I want them to check in, even if it's for a short visit.
I'm feeling great, and I should see you every 3 months?
I still want you to check in with me. It could be that depending on the therapy you're on, I should state, in her case, because she wanted to get pregnant, I wanted to keep her in very tight control. So I was going to do labs probably every 3 to 4 months, as well as check the stool marker, make sure she's in a good, what we call deep remission, this concept of redefining. Plus, there may be new therapies we would want to talk about. A lot of times they want to know, is this therapy I'm going to be on forever? I want to be able to keep them up to date as to what therapies are coming out. Life gets in the way of visits. I do not underestimate that. So even if it's twice a year, if I can see them and really update them on the labs. I think if they come to the visit prepared and understand that there's the checklist we must go through when it comes to the GI symptoms, the side effects of what to expect from their therapies, but I want the patient to redirect and empower themselves to bring the visit to the level that they want those questions answered. For example, the role of diet, the role of sleep, exercise, fatigue, stress, anxiety. Redirect. Kind of make the physician maybe feel uncomfortable because it's not a typical topic of discussion, but I want patients to feel empowered.
I think having a checklist and all those things written down is really important. And I bet there's a lot of patients out there who don't think of routine visits when they're well the way they might need to. And frankly, I think our colleagues don't necessarily schedule them. So this is an opportunity for patients to really learn from this particular video series in our discussion today to take more control of their disease. So thanks very much.
Yeah, thank you.